Enjoy this conversation with me, Maureen Kimani, every Friday from 9 a.m. on our Health Corner show here at Capuchin TV. Your health is your wealth.
Hello and a very good morning to you, dear viewer. Thank you very much for joining us yet for another episode here on Capuchin TV. That is our Health Corner show with me, Maureen Kimani, and this program is brought to you by Capuchin TV in partnership with St. Mary's Mission Hospital. And today, as you can be able to see on your screen, our conversation is all about breast cancer, as we all know that the month of October is dedicated as a breast cancer awareness month. That is to raise awareness on the disease and, of course, to promote early detection and again to support the patients. And we'll be delving into this conversation more details on why is it important to have early screening. And as I just to visit on this year's theme, that is every story is unique, every journey matters. And joining me right now for this conversation, we have a guest from St. Mary's Mission Hospital, and she will be able to introduce herself as we get to delve deeper on a conversation today. In case you'd love to be part of these conversation, do not hesitate to reach out to us on 0717 424 866, or you can use the SMS number that is 21760, and we'll be able to get to read your comments and tell us where you are watching us from. A very good morning to you, Dr. Anne. Thank you for making time and being here to have this conversation with us.
Thank you very much for having me, Maureen, today on Capuchin. My name, as you've heard, is Dr. Anne Musach. I am a clinical and radiation oncologist affiliated to St. Mary's Mission Hospital. And breast cancer is a topic that excites me. So I'm always happy to talk about it, and I'm happy to be here.
All right, and just to, just get into the conversation, because every year we have this conversation about breast cancer on the month of October. What is exactly breast cancer for the person who is watching this discussion for the very first time? And if you visit the World Health Organization research, they say that breast cancer is the commonly diagnosed cancer among women worldwide. And in 2022, approximately 2.3 million women were diagnosed, and another 670,000 were died from the disease. And when you look at this number, these are our mothers, these are our sisters, these are our daughters, they are our friends, and they are our family. Tell us more about this research and, of course, the introduction about the breast cancer. What is it all about?
So cancer in general is when cells that would normally divide tend to divide uncontrollably. They tend to lose their break. So in a normal body, the normal cell, the body is able to do a balance. It is able to destroy cells when they are damaged, when they are old, and replace them with new cells. But now a cancer cell is a cell that has damage, and the body is not able to detect this damage. So it continues to multiply, and as it multiplies, it becomes something in solid tumors that you can actually touch. So when we talk about breast cancer, we are talking about this uncontrollable division happening within the breast tissues. And it can happen, the breast has what we call the ducts and the lobules, remembering that primarily the breast is an organ that is used in breastfeeding. So it can, mostly the cancer would either occur most commonly in the ducts, but a bit rarely in the lobules. And we also have a few rarer cases whereby it occurs even sometimes in the other soft tissue, sometimes even in the muscle under the breast. Yeah. So the data you've given us is pretty accurate. That's what we have of right now. Probably next year we'll be seeing data for 2024. And it's actually a slight improvement from what we were seeing in 2020. So the incidence in 2020 was the same, but the mortality was slightly higher, with 15,000 more cases more people having died from breast cancer. And you would think that with the technology and with the awareness out there, that maybe when we look in future trends, the numbers would be going down. Unfortunately, no. It is actually estimated by WHO that in 2050, we will be having around 6 million new cases worldwide and around 1.1 million deaths. And this increase is going to be attributed to some of the choices we are making right now. We are trying to live a more Western kind of lifestyle. So it's going to come to bite us later. So it is important to talk now about what are we going to do to ensure that it is forecast, that this forecast doesn't come to pass. So as we go along, we'll talk about what can we do maybe in terms of prevention of breast cancer.
All right.
Yeah.
And before we get into the symptoms and the signs of breast cancer, and of course, you can mention, because I understand some men do get breast cancer, because I'm sure of you might be asking, do men have breast cancer? So I think you'll be able to expound that to us. Let's talk about this year's theme. Why do you think it was very important to have perhaps the patients share their story? Because the theme for this year, it's every story is unique and every journey matters. Why do you think it is very important for that theme?
Definitely, every story is unique. Every cancer patient's journey is totally different from the other patient who has breast cancer. And the support that the patient needs is usually also, they need different kind of support. The kind of care we are advocating for, we are advocating for holistic care, not just looking at the patient's physical, maybe the physical concerns. The patient is a whole. We need to look at the social aspects, the spiritual aspects. The theme is advocating for resilience and hope, not only for the cancer patient, but the cancer patient most of the time they don't walk alone. They walk with family. Some of them, maybe they don't walk with family, they walk with friends, they walk with distant relatives. It is advocating for equity. It does not matter whether you're from Mandera or you're from Eldoret. You deserve to get the best care that is out there. It doesn't matter whether you have employment or you're unemployed. As a breast cancer patient, every cancer patient deserves to get the right care for them. So that was what the theme was advocating for this particular year.
All right, that is every patient deserve hope and dignity for these. Let's talk about the symptoms now. When we talk about breast cancer in women, and of course, as I mentioned earlier on, we have men who get breast cancer. Kindly expound on these signs and symptoms that there is for men and for women.
Okay, so first of all, I'll say that for men, breast cancer is a bit rare, about 1% of the cases. And as you just said, because men are like, I cannot get breast cancer, most of the ones we see, actually, I think I've been in this field for more than 10 years, and all the men I've seen come with stage 4 disease, meaning that the disease has moved from where it began and gone elsewhere. I think it's because we do not think that men can get breast cancer. But men are supposed to be aware, have breast cancer awareness. Because now for the men on the chest wall, it usually develops as a lump on the chest wall. And sometimes you might not find it on the chest wall, on the axilla, which in Kiswahili we call kwapa. As you go towards the kwapa, that particular area is also a region where you can get some of these lesions. So men need to be also aware about this. And especially especially, I'm not saying you have to, but especially if there's a strong family history of some of these cancers. Yeah, sometimes there is some genetic predisposition to some of these cancers, especially for men. Now, when we talk about women, yes, there are some of the cases where there could be some genetic family predisposition, but most of the cases actually we are seeing are spontaneous. We cannot find any link. So when we take the histories, most of the patients will tell you, maybe I was in the shower, and as I was showering, I felt something that was abnormal.
Yeah.
It wasn't painful, so I didn't come. I thought it was a boil, and I thought it would go away. Probably I went to the nearest center and I was given some antibiotics, but it did not go away, so I decided maybe to go elsewhere. So most of the time it will come as something that you can actually feel. It could be different sizes depending on whether the person is cancer aware or not. There are those who do check their breasts on a monthly basis, yeah, and there are those who do not check. So for some of them, they really find them when they are pretty big. Sometimes it could also even come from the spouse. The spouse will say, I felt something that was a bit abnormal. And we decided to find out maybe if there could be something else going on. It's important for a woman to stand in front of a mirror and look at her breasts. Because one of the signs is there's asymmetry. One breast might be bigger or smaller than the other one. When you look at them, the nipple sometimes is pulled back in. The other one is normal, the one is pulled back in. Okay. The skin sometimes looks like an orange peel with some small, like you can see the skin pores. You can see the pores of the skin. Yeah. Sometimes as you look at the breasts at the mirror, you can see some dimpling on maybe one of the sides of the breast. Yeah. Then the abnormal discharge. Sometimes the discharge is bloody. Sometimes the discharge is clear. Sometimes it can come with pain. The patient says, I was feeling some pain. And one of the main causes also of the delay is when you do not find the lesion in the breast, but it has gone to the axilla, which is the quapper. Because sometimes you find it in the axilla, but you cannot find anything in the breast. So especially when it goes to the axilla and it's not in the breast, the patients normally assume it's a kind of infection, and they'll be in hospitals for antibiotics for several months before they see you. Yeah. Okay.
Yeah. And do we have an age bracket for a person who can be prone to getting this breast cancer? Or perhaps just to emphasize on that, when can one go for screening to begin with?
Okay, so for screening, our guidelines, our Kenyan guidelines for women who are average risk. So we'll divide women into two groups. We'll have average and we'll have a high risk. So I'll start with average risk. So women who are average risk mainly means they do not have a strong family history of breast cancer or cancer in general. They have not been treated for breast cancer before and have not been found with any abnormality in the breast. It might not be breast cancer, but there could be some abnormal cells. Or in childhood, maybe they were treated with radiation around the chest wall as part of a treatment of a totally different cancer. So if they are not in that particular bracket, we call them average risk. And these are patients you want to start your screening mammogram at the age of 40. And you want to do it at least every 2 years. Yeah. For those who are high risk, the story is a bit different. It will depend on what it is. If you have had a breast cancer diagnosis, you're also high risk. You might have, let's give an example, you had a breast cancer of the left breast and you have been treated, you've gotten everything you're supposed to get and you're now on follow-up. you're still at high risk of getting breast cancer in the other breast. So you'll also be in the group of the high risk patients. So for you, we will not do every 2 years. We will do every year. Yeah, so that just in case it is there, we still also want to get it early. Our target is cure. We want you to continue with your life. Yeah. If it's somebody who was treated, so we have a disease called some of the lymphomas. Part of the treatment in childhood is radiation. So sometimes you find the lymphoma is around, middle of the chest. So you end up giving some radiation. So this particular child, you will look at what age was this child given radiation treatment, and you count 10 years, and you will start screening, but not with a mammogram from the age of 10. There you would probably want to use an MRI. It would be more accurate. A mammogram would not help you, because let's assume maybe the child was 10 and now 10 years, the child is now 20, is now an adult, and a mammogram will not help you in that particular age bracket. Yeah, so if you have a strong family history, so we also have specialists called genetic physicians who they're able to look and advise, like they look at the line and they advise, maybe let's look for a deficit in a certain gene. And like the Angelina Jolie, the Angelina Jolie story, yeah, she had a gene that was found to be mutated. And so you have these specialists who now, when you find the gene mutated after the mother had breast cancer, she also had a mutated gene. So to reduce her risk of breast cancer, what did she do? The gene, we call it the breast cancer gene, BRCA, there's 1 and 2. So to reduce her risk, she had what we call a mastectomy. Both the breasts were removed. And because the gene, it is not just breast cancer, it can predispose to many other cancers, including ovary. She also went and had her ovaries removed. So if you find somebody who has this particular gene, this is somebody who you will not wait to 40 years. You'll probably start the screening much earlier, probably around 25. And you start probably, at that age you will use a mammogram and you will use an ultrasound. So it will depend on what is the risk this patient carries, and what would be the best modality that will give you a correct result. So that is what would determine. But for most people who are average risk, we talk about from the age of 40.
Okay, yeah. All right. And we mentioned that men also do get breast cancer. Perhaps can they also come for screening?
So we do not screen men for breast cancer. So there's a criteria about which cancers are screened. So number one, you need the numbers. Yeah, you remember breast cancer in Kenya is the second in mortality and first in incidence. So we have high numbers. But if you look at inside those numbers, you'll find the majority are women. Men are less than 1%. So for the men, the numbers would be low. Yeah. Okay.
And during your introduction, you mentioned about lifestyle changes, and you're very excited to speak about that, because I know there's a very high concern, not only just for the breast cancer, even in other diseases. When you look at the diabetes, for example, tell us how does lifestyle affect your life as far as our conversation today is concerned?
So when you look at the risk factors for breast, the better way is to divide them into two groups. There are things we can change, there are things we are not able to change. So what we can change are things like living actively, not sitting in front of the TV all day, going out, taking walks, doing runs, doing marathons, going to the gym. What you eat is very important. You need to eat healthy and balanced diet. If you can know where your food comes from, the better, because you would want to avoid foods that are also heavily contaminated with chemicals. Alcohol and cigarettes have been linked to so many cancers, including breast cancer. So that is something that if you are indulging in, it's something that you would want to probably stop. Cigarette basically stop completely, alcohol reduce completely until to a point that probably it's not among what you consume. On the other side, there are things we cannot change. You cannot change the kind of family that you come from. You cannot change. Yeah, I know they say they can change from a woman to a man, but you really cannot change. Just being a woman in itself, you're already a risk for breast cancer. You cannot change the fact that you're growing older, because the older you become, the higher your chances of getting breast cancer. You cannot change your genes. So we can only work on the ones that we can be able to modify. Yeah, they are not difficult things to do. And you see, it will not just prevent you, because there are men watching, they'll say, my risk is less than 1%, so I'll continue doing my thing. But it will prevent, those things prevent you even from other cancers that we are not talking about here today.
You mentioned that you have an experience for over 10 years in your field, and perhaps you can talk about the importance of early detection, and that's why we have this conversation, and that's why the month of October is set to create awareness on the breast cancer. That is to raise awareness on the disease, and of course to help and tell people to go for screening, and of course the importance of early detection. Perhaps if I take you back, you mentioned about family history. Sometimes when you have someone who had breast cancer in your family, you might be very hesitant to even go for screening, or even afraid, because you already know you might be prone to having this breast cancer. How do you perhaps encourage the viewers or the patients who have gone under that process?
So maybe if the most important sentence is the one I'm going to say right now. There is cancer is not a death sentence. Yes. And even when we talked about the numbers of 2020 and 2022, we talked that there is some reduction of around 15,000. 15,000 people is a lot of people who did not die in 2022, but who were in the number in 2020. This kind of differences can only be attributed to screening. One of the reasons that we still have, like if we talk about, we've not talked about the Kenyan numbers. So if we talk about our numbers here in Kenya, and I'll tell you, they are not accurate because not everyone is reporting the cases. So in 2022, we had 5,700 cases, and we lost around 3,200 people to breast cancer. That is significant. So the screening, we screen cancers whereby our screening will help bring a difference in the mortality. We want people to live longer. So if you come for screening, most likely we'll get, if it is there, we'll get it early. We want to get, actually we want to get it before it becomes something. We want to get it before you touch yourself and feel there is a mass. We want to get it on the image as a very small thing. Because if we can get it early, we are talking about cure of more than 90% of the cases. Yeah. Yeah. Breast cancer is not one disease. As we said, every patient's journey is different. They're different. Yeah.
Okay, interesting. And perhaps you can tell us, or you can try to define the different stages that we have when it comes to breast cancer, and perhaps you can tell us how do you help the patients to evolve and to continue living through this journey? Because I understand that when you hear some of the diseases, or even when you go to a hospital and the doctor tells you you're suffering from these diseases, so the first thing that comes to you is you start worrying about yourself and the people around you. Already that one has an effect. So when you talk about breast cancer, take us through these stages that we have.
Okay, so first of all, the patient will present either from a screening, or the patient themselves will present to the facility. So for example, in the cancer center, sometimes we see patients who we haven't diagnosed. And a lump in the breast does not mean you have breast cancer. We need to check and see Sometimes it is not breast cancer, sometimes it is just some cells that are not abnormal, there's nothing atypical. So the only way we can put that diagnosis and say somebody has breast cancer is once we take a sample and have the pathologist examine it under a microscope. Once it is determined that this is actually breast cancer and it is invasive, as in it has broken the cell where it started, it is out of the cell, then we need to check the rest of the body to see whether it has spread anywhere else. Yeah. So what you do will depend on what are the symptoms the patient is presenting with, and when you look clinically what you see. But like a standard, probably someone will get a CT scan of the chest and a CT scan of the abdomen. And if a mammogram hadn't been done, you'd also do a mammogram, because there are cases where we get disease in both breasts, so you would want to be on top of it. So now, with that, now you would get to the stages. So basically stage 1 and 2 is early disease. Stage 1 is limited to the breast. Stage 2 also limited to the breast, but sometimes you have a few of the what we call lymph nodes that may be affected. Stage 3 is still also local disease, but you have more of the lymph nodes affected. And stage 4, the disease has moved from the breast to any other place. So from the breast, it can move to the bones. So I'll go back to the symptoms. It depends on where it has moved for stage 4. Some of the patients will present with fractures, or they'll present with pain in the back. It might move to the liver. Patient will present with pain in the abdomen, or it can move to the lung. A patient can present with difficulty in breathing. Yeah, but so it will just depend on how the patient presented, and now it will determine what you need to do. Yeah, it can also go in some of the cases. As I've said, there are different diseases. Some of them are a bit more aggressive than others. So for some of them, you would find that the patient presents like someone with a stroke, maybe with convulsions. So you would need to do a head MRI to see what is happening. Yeah, so that would give you the stage.
All right, and let's talk about the treatment options that we have in our country, and especially at St. Mary's Mission Hospital for breast cancer patients. What are some of the options they can get when they come and pay a visit at the hospital?
So the first thing, we do screening first of all for the 5 cancers that we screen in Kenya. It's a center that has everything for screening. We will screen the breast, we will screen the cervix, we will screen the prostate, we will screen the colon and the esophagus at St. Mary's Mission Hospital. When you come now to the cancer side, we are able to do surgeries. We have a wide range of medical and surgical specialties. So most of the surgeries we are able to do in-house without referring outside the facility. We are doing chemotherapy also under the St. Mary's roof, which is covered by the SHA. Most of our procedures are actually covered by SHA. So we do chemotherapy. And you know, when I say chemotherapy, it has a lot of meaning. There is chemotherapy can be an oral drug, can be an intravenous drug. There are even some which are topical. And right now we are moving to a new era of drugs. We have what we are calling targeted therapy. That's why I told you the breast, there are different diseases. There are some breast cancers that we will treat with targeted treatments, which will give them a very good response. And we also have immunotherapy, which just in summary, it is said that we all have cancer, but it doesn't develop in all of us because some of our immune systems are really good. They're able to detect and attack. So immunotherapy is using the same principle. It just like awakens the body, our body's immune system. So the immune system is the one that fights the cancer. So those are therapies that are also available in Kenya. They're slightly more expensive, but they are available, and their response is very good, especially for advanced disease and for metastatic disease. So there are other treatments for cancer which may not be under the St. Mary's roof, but like, for example, radiation therapy. But we are able to guide the patient to centers where we have collaboration with. So it's just a smooth transition for that particular part of of the treatment. And I'll also talk about palliative care. It's a slightly different discipline, but basically it's a work with the patient, a more holistic work that looks at all the aspects, the spiritual, the physical, the social aspects of the patient, not just the one part. Yeah. So we also have palliative care in-house. They help a lot, especially cancer diagnosis is not an easy diagnosis to break to the patient and relatives, and it's also not an easy diagnosis for them to take. So we have them in-house. When we do the breaking of the news, we have the psychologists from the palliative care sitting with us, the counselors from the palliative care, and also the nurses. Yeah, so palliative care is also one of the treats. So with palliative care, some of the patients, it's usually a discussion about the treatment. You do not impose your opinions on the patient, you give the patient the option. And sometimes some of the patients you will go more into best supportive care rather than active treatment, because sometimes maybe they cannot tolerate the active treatment, or maybe they are a bit too old. So palliative care comes in there at that point. So usually every patient, when we begin, we start the work together with the palliative care team. Yeah.
Okay. And when you take a look at the world that we are living in, the technology has really advanced, and perhaps when you go out to the society, and especially to the interior, in our country, interior places, you find that there's a lot of information surrounding breast cancer. What are some of the myths and misconceptions about breast cancer that you've come across with for the last 10 years?
So one is about the men. The men cannot get breast cancer. The second is if the surgeon touches that breast, then it will spread. Actually, that is a very wrong misconception. So surgeons come in two ways. One, we want to know what that lump is. They will take for us a sample. And second, we use surgery curatively, which could either be removing of the entire breast, or it could be removing part of it. The other misconception is if you get chemo, you will die. We are very careful on our choice of chemo. Who has indications for chemo? Will this patient tolerate this chemo? And every time before we give it, we also check. We have to make sure you're good and you're fit. Yeah. So those are some of the misconceptions, and now they lead to the patient going to some of the alternative treatments, and some of them maybe don't work so well for the patients. Yeah.
All right. And sometimes you find when you have these breast cancer patients, after you break the news to them, they may be hesitant to continue with the medication. As at St. Mary's Mission Hospital, do you do like a follow-up to ensure that your patients, you walk through, because you mentioned about palliative care, you walk through the patients through counseling and ensure that you help them to understand the importance of, going through this chemotherapy and, of course, medication bit of it?
Yes, that is very important. We actually do. We have a new program that is coming up, what we call a navigation program, to help us with the follow-up part, because sometimes once you break the news, the patient goes into denial, and denial can also waste a lot of time. So we have the navigation team, which would follow up. Our nurses would call and find out how is the patient doing, what is the decision, and even guide them, because sometimes maybe the patient has come in from the counties and they would feel more comfortable being near home. So they're able to even guide them if we are maybe, because there are other smaller centers, maybe sometimes we coordinate with them and refer them to the nearest, just to make sure that they have the support that they need to start the treatment. Yeah.
Okay. Thank you very much, Dr. Anne, for that, dull information. I'm sure it's a very insightful conversation, not only just for the women, even for the men, because they can help to educate their spouses, their sisters, and of course the society, because we ensure that as Capuchin TV, we continue. The conversation doesn't end here, just creating awareness. We help even the churches to ensure they have these discussions, the women's group, so that they can be able to, give out these information about breast cancer to ensure everyone lives healthy. Let's talk about how do you handle cases of advanced, that is metastatic, breast cancer. Tell us more about that.
So it's important to be transparent with the patient. It's important, so you have to assess what is the psychological state of the patient. You do not have to give the patient too much information at one time. You can tailor the information in small bits, because the patient is under your care. So for those ones who are metastatic, as I said, breast is it's a heterogeneous disease. Some of them will get chemotherapy, some of them will get chemo and targeted therapy, some of them will get hormone therapy. Some of them, depending on what is the presentation, we might even start with some radiation. Maybe there is pain in a bone somewhere. We might not start with the chemo, we might go for the radiation first. You need to sort out the pain. Your target is you want to give this patient the best quality of life. So their survival will be different depending on which type of cancer it is. The ones that are hormonal will tend to have a better survival. I'll give you an example. There is an old lady I've been working with. I met her when she was already stage 4. She had a mass on the breast that was needed radiotherapy, and she refused the radiotherapy. So we just started hormones, because you cannot force your ideology on a patient. That was 2019. She's still very active today. She's only on hormones. So it depends. They're different. They are different types. Some are a bit more aggressive, and some are the survival of others are a bit more friendly. So you just have to make a balance depending on who is in front of you. How does the patient look? When you have that discussion, you give them the options, and I tend to let them think about it, not to force them into making a decision. Sometimes they say, hey, this one we have to go and sit down with the larger family. I'm like, it's okay. Go sit down. If you need us to sit down again, we can sit down. We do have what we call family conferences in St. Mary's, whereby the family will gather themselves, tell us we will be available on this day, and the team in St. Mary's will avail themselves, and we have a sit down, and we go through, okay, this was the presentation, this was the biopsy finding, this is the stage we are having, and these are the options that we are going to have. So depending on that discussion, patient-centered, because sometimes the relatives are saying something different. You listen to also what the patient is saying, because that is the person you're treating and not the relatives. But it has to be inclusive. The patient is the one who decides which relative comes to the meeting. So you have the meeting, and from there you come out with a decision. Yeah.
All right. Let's talk about breast cancer recurring after surgery. What are the chances of a breast cancer recurring after surgery? And of course, you can talk to us what a patient needs to do before going for any surgery.
So, the more aggressive cancers, so maybe I'll just mention them. We have, the patients do know which ones they have. We have cancers that are called triple negative. They are not sensitive to hormones, and they do not have a target. Those ones tend to be a bit more aggressive. You tend to find them in younger patients from around the age of 30, less than 40 basically. And those ones have a very high chance of recurring, even when you do everything right. Yeah. And we also have one we call HER2-positive disease. It has a target. The targets have evolved over the years. Unfortunately, in Kenya, we are still stuck on the first target. That's what we are able to afford. So you'd find that these particular two groups are the ones who would be at higher risk of getting a recurrence. The ones who have hormone-positive disease, they also can recur, but you would find it much later, like after maybe 10 years, 12 years, but a bit more rare. So the patient, remember, once we finish the active treatment, we do not discharge the patient.
Okay.
So if we are in Nairobi and the patient came from, let's say, Kisumu, and we have finished the treatment, we'll have the discussion. Do you want follow-up in Nairobi, or do you want me to move you to a cancer center within Kisumu? So depending on what it is, if the patient says in Nairobi, we'll put the patient on a follow-up schedule. So within the first year, we'll see the patient at least every 3 months. When the patient comes in, we will do a clinical exam. Every year we'll do at least a mammogram. Also, depending on how the patient presents, we might do other scans in between. So if we do find that there is something, we will take another biopsy, because sometimes they do change. You could find it was a hormone positive and now it is not. So we will take another biopsy. We will restage the patient again. Want to see, is it just there, or has it gone elsewhere? And if there is an indication for surgery, we will go ahead and do the surgery and maybe give a different line of treatment and put the patient again on follow-up. So maybe something very important that I forgot to say. Treatment decision is not dependent on one doctor. For each and every patient we see in St. Mary's Mission Hospital, we do have what we call a medical tumor board, whereby we summarize the case, and the case is presented to different specialties. So we have several oncologists on the call, we have several surgeons, the social workers, the nurses, the palliative care, the radiologists, everybody, the pathologists. We discuss the case and we come up with a decision. So at each and every step where we are going, the treatment is not working, or we are going to initiate treatment, if something is not right, we take it back to the tumor board. And that is the golden standard, that each and every patient is different. We cannot take one blanket and treat everybody the same. So the tumor board helps get the best for that particular patient. So that is what we do for them. Yeah.
All right, and that's why we recommend patients or even anyone just to go for a normal checkup at St. Mary's Mission Hospital, because they have a good health experts and doctors to assist you and to help you walk through your health journey. I'm just curious to know, because you've seen very many trends of women getting breast implantation. Can it have any effect for one to get a breast cancer?
Not documented.
Okay.
Why I'm saying that is actually where we are moving in our breast surgery right now, because aesthetic is also important. You can imagine a 30-year-old, a 30-year-old has been diagnosed with breast cancer, still a young lady. The loss of a breast can make someone feel a bit underwhelmed. So right now we have, even in St. Mary's, we have breast reconstruction. So as I've said, it's a discussion. So some of the patients will tell you, me, I'm okay. I'm okay with it. It doesn't affect me. But some of the patients, it does affect. And we have reconstruction whereby once it is removed, we use, okay, I'm not a surgeon, but we use muscles. We use sometimes abdominal muscles or muscles from the back to reconstruct that breast. And some of them, even we put some of those expanders to ensure that after we've done our treatment, we are going to be able to put some of those, some of the, like the what are they called? The silicone. Yeah. So when we look at the risk factors for breast, it hasn't really come into that space. But medicine changes every day. You see, like for smoking for many years, it wasn't linked to cancer until one time somebody actually found it linked. So we never know, in the next few years, maybe that will change. Yeah.
Okay, all right. And what support is available for patients who have breast cancer?
So number one, we work like a team. So even in the oncology department on its own, you will find that we have the navigators, we have the social workers, the psychologists, the counselors, the nurses, oncology nurses, the palliative care nurses, and each and every person has their role to play. When it comes to support for treatment, we have organizations like the Faraja Cancer Trust, which has helped so many patients who are having difficulties with affording treatment by paying for their chemotherapy treatment, paying for their radiotherapy treatment. Yeah. And we also have in different hospitals, you see, I've talked about some of the drugs that are very expensive. So as the cancer sphere, we are connected. So we know that, for example, if this patient needs a certain drug that I do not have, if I send this patient to Nairobi Hospital under this program, the patient will get that particular care. Or if I send this patient to KUTRH, this drug is available in that particular places. We've also entered into clinical trials. We have several clinical trials that are ongoing in Kenya. So some of our patients, if you find a patient eligible, it gives them access to drugs that have not yet hit the market, good drugs that have not yet hit the market. So some of the patients who qualify, we explain to them and we send them to clinical trials.
Okay, yeah. All right. And I understand we're running out of time. Perhaps as we wind up with a conversation, what message would you like to share to the breast cancer patients who are, struggling and living through this life, as far as our conversation is concerned, and for those women who are afraid to even go for screening? Perhaps you have something to talk to them about that.
So one thing I've noticed about patients is they are not aware that we as healthcare workers sometimes are able to link them to the necessary support that is available. So you would find a patient is delaying treatment because they do not have money, and yet maybe it's just that we do not know. It has not been voiced out. So I would encourage them to in their centers, the cancer patients in whichever centers they are, you know the nurses, you know the doctors, identify one who you can talk to. Do not keep some of these. Sometimes they are going through a lot of social issues, financial issues. Mention it to the doctor. You never know, maybe there is help that the patient can be linked to. So don't keep it to yourself. Also reminding them that we do have a lot of support groups. For those who are not in any support group, we have a support group for patients at Faraja Cancer Trust. You can join their support group if you don't have a local support group where you are, but most of the cancer centers do have support groups. And these support groups do help not only the patient, but also the relative. It is a very difficult journey to navigate. So they are very important in giving you the hope, the strength, the resilience to be able to walk this journey. Because when you start the journey, it looks like it will never end. But when you sit in these meetings and you hear somebody who has already walked that journey and is now 10 years cancer free, it gives you the motivation to actually take on your journey. Yeah. The message I would want to give to those who are afraid of screening is...
And perhaps on that, you can talk even the ones who are going through the stigma in the society. Yeah.
So the ones who are afraid of screening, cancer, as I said, is not a death sentence, especially if we get it early. The cure rates are more than 90% for breast cancer. So if it is there, it's better we get it early, because when it comes, when it's more advanced, it's even more expensive for the patient, and the options become limited. Stigma is there. Stigma is real, and that is why I think last year we had palliative care talking about compassionate communities, because you see some of these patients, what they go through when they are diagnosed, sometimes even the spouse can walk away and the patient has nobody. We have seen cases whereby the person who supported the spouse is not a relative. So what I would advocate is we need to change our mindset about cancer. We need to support our family members, we need to support our friends, we need to support our neighbors. Yes. Let's build these compassionate communities, because today it is this neighbor. You don't know about you tomorrow.
Yeah.
Tomorrow you might be the one who is in need of this particular support. Yeah.
All right. What a way to end up with a conversation today here. Thank you very much, Dr. Anne, for making time and for shedding more light about breast cancer as we continue to work together with the patients who have breast cancer in this journey and promoting and raising awareness about the disease itself, and promoting early detection. Why is it important? And I hope you've been able to learn more about that. Thank you very much for watching and for tuning in to our Health Corner show. My name is Maureen Kimani, and our guest has been Dr. Anne from St. Mary's Mission Hospital. May God bless you, and remember that your health is your wealth. Thank you, and God bless you.
Thank you.
Enjoy this conversation with me, Maureen Kimani, every Friday from 9 a.m. on our Health Corner show here at Capuchin TV. Your health is